Hi, good afternoon, everybody. Thank you very much, Mr. Chairman, for such a nice introduction. So, as I was introduced, I'm going to talk about the European perspective, which is a little bit different from the North American. We tend to use lesser axes, but anyway, it's not only dairy, it's also beef and veal. You're aware of that in several countries we have different systems, which all have the economical value. So, you all have seen this kind of pictures. You have studied them, the multifactorial origin of different diseases, in this example of BRD. This slide is going to come back from time to time. So we have pathogens, we have immunity, we have climate. So when being asked to do this presentation, I just ask myself, hey, what's new on BRD? What's really new on bacterial pneumonia? Well, it was not easy to find answers. I went through literature, as I do quite often in my job, and then I tried to find changes in prevalence. Do we have good prevalence data for Europe? I was disappointed, because in live animals, acute diseases, we do not have a lot of reports. I showed them, they're just five good ones. Not even every country is represented in that. Risk factors, we do know so much about risk factors, but we do not know in every system the relative weight of them. We do not know what we need to adapt first. Is purchase more important than housing, etc., etc. It's different from system to system. Immunity. Nice work has been shown with new vaccines, but also on the very young calves. We still have this issue of maternal immunity, vaccinating dams to protect the calves. Is that possible, yes or no? And then, of course, I really love what Edward is doing. His work on early detection, and that's really the key. But it's still the curative side of disease. And preventing disease, preventing flu in humans is way more cost effective than curing animals. What's the price of all these technologies we're going to put in that? They might work, but we need to know whether it's cost effective to use them. Cough monitors are another example, which are also being used nowadays. So what's really new on bacterial pneumonia from a European perspective? I think you guys all read the papers, you follow magazines, you've heard of words like resistance, drug use, ESBL, MRSA. The guys from the Netherlands, they sure have had already enough of that today. But it's actually a global trend. It goes from the north, from Europe, towards the south, and there's no turning back. I'm from the Low Countries, and in our country, it's getting more actual. It's actually putting a bomb under agricultural production, under intensive production. And we really need to take this into account. So what really changed is actually our societal background. That's what changed. We have to produce under different circumstances. It's not only about the societal pressure. You're all aware that the economic situation is not that perfect, that our farmers really have to cope with several things right now. Societal pressure, environmental impact, I do not need to explain this. You know what they say about cows and their burping, etc., etc. Animal welfare, do not underestimate that. People do not want animals to suffer for their meat. Some countries, like I'm residing in Switzerland right now, it's amazing to see how different the mentality of people can be and how it changes. And this is also something you have to take into account to your own financial benefit, because people pay more for labeled meat. They really do. Antimicrobial use and resistance, that's the big issue. That's where we get the human doctors and the complete society against us. So we really need to take this into account. Well, I do not want to lose my time talking about antimicrobial resistance and the germs. But I do think it's my duty to inform, for those who are not yet aware of it, how the situation is. I want to show you on commensal bacteria, pathogens, and zoonosis. Just a quick overview. You do not need to read this slide. You just have to look at the colors. How many colors do you see? Everybody knows that this one is different from the other ones. Well, that's dairy cattle. The other ones are veal calves, poultry, and pigs. So what's the common factor? All of them are actually intensive industry, which use oral medication. Whereas the veal calves, whereas the dairy cattle, as you know, we do not orally medicate them. So it is really a trend going on. Many countries are monitoring these so-called indicator bacteria, like Escherichia coli or Enterococcus, and they see this kind of trends. The second thing, when you go to zoonosis, then it starts to become politically important, as you might be aware. So LABORATORIOS, livestock-associated methicillin-resistant Staphylococcus aureus. You can see, for example, in our veal producers and our pig producers that many of them actually carry this bacteria, and many farms are positive. Well, I'm a vet, just as you guys are. I'm a carrier. I do not know whether everybody will still continue talking to me, but 7.5% of you guys and girls will still be a carrier, either permanent, either transient. And that's the situation how it is. You do not have to be that afraid of it, because when you are immunocompetent, then the only thing that might happen is when you get wounded. But we do have a profession where you can have these little wounds on your hands from surgery, etc., so it's not unlikely. And then you get a nasty wound infection, which requires time to healing. That's it. But this was a bit big fuss, really. There was a lot of political talking about it, especially in the Netherlands. It was the basic of their rational plan to reduce antimicrobials. But now we have good knowledge, thanks to the Dutchman. And they've seen that it spreads quite difficult from one man to another. That's one thing. And the second thing is that the contribution of this livestock-associated MRSA to bacteremia in humans is quite limited. So every time I'm tested at the clinic, I just go swimming afterwards. With the chloride in there, it will disinfect my nose. Make sure your head is under the water. And at the clinic, we just do disinfection. We wear gloves. We really do. All of this our students do. And then the situation is carried out. Finished? I don't know, because a little bit later, this turned up. Extended spectrum beta-lactamase. It's not a bacteria this time, it's an enzyme. An enzyme which renders Enterobacteriaceae, like E. coli, Klebsiella, etc., resistant against our beloved third and fourth generation cephalosporins. Especially for dairy farmers, they are so precious for them. So they're on plasmids, mobile genetic elements, and they can just move from one bacteria to another, from one species to another. A very dangerous situation, and people, the negative people, believe that we have already lost the fight against ESBL worldwide. It's a poultry issue and it's a veal calf issue. You can see here from 4% up to 40% in about 12 years of time. So that's quite impressive. For you in practice, from time to time you do an antibiogram, I think, with this diffusion test. Then you get a result like this. It's in Dutch, but you can do it in whatever language. Well, if you want to recognize such an ESBL type, you just have to look on resistance for ceftiofur or cefquinone, resistant here. And if you have this one, you can still use amoxicillin clavulanic acid. Will still work. However, if this will also turn resistant, then you have a very special ESBL, and that's an AMP-C ESBL. So it means it is resistant against both cephalosporins as actually amoxicillin clavulanic acid. Really a nasty one. But most important is this. These are the Pastorellacea which we are talking about today in function of their system. You can see the difference. You can see quite nice here that in veal calves, too bad of the pointer, in veal calves here, you have multi-resistant strains. 64 up to 80% of them are actually carrying resistance genes to different antimicrobials. So in the systems which use a lot of group medication, you got a lot of oral medication, we just see more resistance. And this trend just continues. A very nice article by our epidemiology group has just done this on a national level, showing the link between drug use and resistance. These results, every scientist would kill for that. Such a nice line, you see. They just looked at how many drugs does a country use and how high is the resistance level. I'm a bit ashamed that I'm right up in the corner there with my country. But anyway, at least we are monitoring. At least we know what we are doing, because many countries are not even on this graph. So within Belgium, this is the drug use. You can see that our veal calves, for example, that they use quite a lot. But I always make this kind of remark on these graphs. It's a way of calculating with standard daily dose how much drugs have been used. Well, you see there 160 kilos. That's the apparent average weight of a veal calf. So of course it is overestimated. And we have to be careful with these kind of formulas because they can easily be manipulated. So we need to standardize on the European level. That's what we want to achieve. That's the Maran report, a very nice example from the Netherlands. They were at 35 approximately daily doses. They decided politically to reduce within a couple of years by 50%. So drug use goes down. Good. On the other hand, you have to take into account that people are not only looking on drug use, they look on animal welfare. And the best indicator for that is mortality. So we cannot call something which reduces by 50% in drug use, but increases mortality as rational drug use. Many countries build up formularies, guidelines for veterinarians to help them which antimicrobial needs to be used for what indication. This is a Belgian example. Differs a bit around the countries, but most of the time you have molecules here in red which are really important for human medicine and cannot be easily used. They make rules. They force you to prove by diagnostics that you need a certain antimicrobial in a herd. This is again the disease. This is the multifactorial disease. How are we going to deal with it? So I will focus on Histophilus somni because Eduard already told a lot about it. So these are reasonably good studies on prevalence, the ones I found and the countries represented in that. And you can see that Mannheimia and Pasteurella, it's at the herd level because I'm really interested in the herd level. Which herds do have this germ present there? You can see that most of them have Mannheimia and have Pasteurella. Histophilus is quite rare, Mycoplasma, depending on the type of herd. So I will come back on this apparently low prevalence of Histophilus a little bit later. But that's the info that we have. It's not that much, of course. So what are the clinical signs? We have seen the material of Eduard. You have the septicemic form with the meningitis, the myocarditis, but we also have pneumonia and reproductive disease. So pneumonia, that's actually one of my last herds in which we diagnosed Histophilus. I did never expect to find it in this herd. You can see that the calves are wearing transponders, so they have an automatic milk delivery device, and they are having a continuous system. Calf goes in, calf goes out. Here you can see a ventilation test. If the smoke doesn't go away within couple of minutes, you have hypoventilation, ammonia will accumulate. So Histophilus somni is just a player like any other Pasteurella in a multifactorial disease in which in this herd, ventilation is of course one of the primary factors which needs to be attempted to. So pneumonia, you open them up. Of course, we also do, and we motivate people to necropsize. These are some histological findings. Typical vasculitis lesions you can also have in there. And that's the killer. That's my fear for Histophilus. You find animals like that, depressed, lying down, sleeping. My student is a little bit over-enthusiastically stimulating, but the calf is not responding. A few minutes later, it stands up, it walks around, and then it becomes dull again. A few hours later, you find it dead. And then it continues, one animal after the other, after the other, after the other. That's Histophilus. That's the fear of the farmer. You can compare it with diseases like, for example, botulism. That fast it can go. That's another example, how animals arrive at our clinic. Sleeper disease, you can imagine why. It's really just being depressed, like they fall asleep. You try to stimulate it. You can clearly see clinically that it has a central nervous disturbance, that it's not reacting on any response. So how do we deal with this? This is a bacterial meningitis. Prognosis is not good, 30% survival. Also in human beings, survival of bacterial pneumonia is not good. What do they do in human beings? When one kid gets a meningococc infection, they dose the complete school and everybody who has been in contact. That's rational for such a highly contagious situation, as they might call it in this. So this is what we do. Clinically ill animals, for example, this animal has received fluorophenical and fluoroquinolones. We treat them quickly and with drugs which penetrate into the brains. Here we were lucky because that's 4 days later. You can still see that the animal is not normal. Do not expect an animal with meningitis symptoms just to become normal within a couple of hours. It's a month work because that's the same animal on day 7. You have this progress going on, but you can see very nicely that he's not still able of eating in a normal way. He's still showing neurological deficits right there. The outcome, slaughtered. 1 month later, he was just normal again in the herd. It might be the exception of the case, but what is really important is our herd management. When we have cases like this, the whole herd is metaphylactically dosed, and animals are monitored for temperature and for the first clinical signs. Otherwise, it really becomes a great disaster for the farmer. For diagnosis, Some people do it in the field. Some people even open up the heads of the calves. So please be aware, if you see this, the dura mater is still on the brain. And it might look like a meningitis, but it's actually nothing. It's just the normal vascular structure of the brains. So you really have to remove this. You have to look in a histological way for the typical lesions. And that's actually still our gold standard diagnosis for Histophilis somni, thrombo, meningoencephalitis. So you can see very nice that it's not thromboembolic anymore, it's thrombotic. It means that it produces the thrombus at site. There's no embolus going around, as was said years ago. Some histological features of the myocarditis. You see the bluish spots, that's actually the signs there. This is in detail. So we do see it, but not that clearly macroscopically, unfortunately. Okay, how are we going to deal with this, this multifactorial disease? You can give me the answer. It's quite simple. If we cannot, for economical reasons, just treat animals, but we have to do it preventive, then we need to know things about all these factors which play a role. And we can do this in two ways. We need a lab diagnosis. I'm focusing right now on the pathogens today, but you can see that things like nutritional status, colostrum uptake, that's also something you can test in the lab, whether it's okay or not. And the other thing is risk factor analysis. Just have a list. Just quantify what is being present on the farm and try to find those 3 factors which are most important and change them. Because a farmer does not want a list of 20 things to change when he already has 3 animals dead. He wants clear communication. And you should be able as a vet to pick out those 3 factors which you believe are most important. One tip, I do not have evidence for this, so please don't blame me. But when you have the Histophilis somni outbreak, reduce density of the animals. Try to put animals in another place, because it's especially in highly stocked beef stables that we see these kinds of outbreaks. So we all learned this. Doesn't matter from which country you come. We sample. We have to diagnose before we treat. That's what we learned. And when we have treated an animal, then we have to do all what it is in our power to prevent disease. We take preventive measures, it goes back, and we control the disease. I can only speak for my country, but I think that we have to admit that in practice, the situation is very like this. The farmer calls us, he has a problem, we do not have time or we do not have the financial means of the farmer to actually diagnose the disease. So we treat. Animals are better, and there's no question anymore of the farmer to come back to us to take preventive measures. So this goes on, and we keep on playing fireman. And you can, of course, see what is key here, treatment, drug use. That's actually the key in this kind of approach. So if you do want to sample, and you will be obliged to sample if you are going to live in a country which actually requires that you have proof for certain antimicrobials, then you have to sample animals. Do not sample them who are obviously sick, because many of them have already been treated. You do not want an animal to die just by the stress of manipulation while you are doing the sample. So in my personal experience, there are 3 things which you can use to select an animal. Have a look on a distance. Animals which are depressed, ears go down, head goes in front. That's important, because depression is a sign of pneumonia. It means that the infection has gone deeper and is no longer in the superficial airways there. So depression, droopy ears. 2 is fever, and 3 is a positive tracheal reflex. You take the trachea, you pull on it, and when they cough, it's a positive reflex. It's incredibly how sensitive that technique is. Although people use a scorecard, like Sheila McGurk, for example, from the United States, she works a lot with scorecards, with very simple clinical signs to be used to improve the detection of BRD. That's also working fine. That's my personal favorite. To be honest, I'm an internist guy. I should be very good in clinical examination. I should use my stethoscope all of the time. To be honest, when I do a herd health visit, I screen calves with this. I do my 3 clinical signs, And then I have a look with the ultrasound. And you know, when you do a herd health visit and you want to convince the farmer of something, you need to have these little moments in which his ears are open, that he's ready for a message, and then you have to get him. You can create it with this ultrasound. Because with an ultrasound, you can really see what's going on. And visually it works very good. So there's just a simple Tringa, a simple rectal ultrasound which you use for your diagnosis and repro diagnosis. So you can use that model because it doesn't need to penetrate quite deep for the lungs. So you can go on both sides. You go, this is on the right side. You go from behind to the front, and this is a normal image. So you just see all parallel lines. We call them reverberation lines. And that actually, reverberation means that there is gas present in the lung. You also have to look at the surface of the lung. So this white line, where the parallel lines start, that's the pleura. Follow that line, it should be nicely and flat. So this is normal, you've got it in your mind. This is abnormal. This is actually a very acute stadium of a pneumonia. You can see the difference. Whereas we had the reverberation lines, now we can actually go and watch deeper inside the lung. We can actually see that the lung tissue has been consolidated. We also see some kind of artifacts, which are comet tail artifacts. They are actually the white beams which start. They do not start from the surface of the lung, they start a little bit deeper. And that's a typical finding of acute pneumonia. It works particularly good in the calves I work with. I work with very small calves, 2 weeks old, up to a couple of months. In the older animals, it's still possible. When we are facing adult animals, it becomes more difficult because it's more difficult to reach the cranial lung lobes. So this is the image of that animal. It was taken in where you have the figure 2. So here. So this kind of lesions, which is actually an acute catarrhal pneumonia, not yet lethal actually at that time, this looks like this. So ultrasound is really one of the most sensitive techniques that you can use for your early detection of BRD. When animals die, you should necropsy them. Why? Because it gives you information. But however, there is a very big difference. If you are on one of those more small herds, or on a herd like veal calves, like maybe South European feedlots, which medicate in the feed, you have to be careful with the conclusions you make. Because you can imagine that if animals have been drug dosed before and they die of the chronic disease, that the bacteria present in this animal have already suffered an antimicrobial pressure on it. So they have been selected, and they might be more multi-resistant than actually the germ which has done it in the first place. So many reports which are based on necropsy results are actually overestimating resistance right now. Let's play a game. 4 cattle, 4 times dead. Who wants to make a guess? There's only one which has a pathognomonic sign, which you can actually diagnose. And I will help you because of time reasons, I see here. Here you can see emphysema. So that's a typical case of RSV virus. You can still get it out. But here in this kind of lung lesions, they are all kind of chronic lesions of animals which were doing quite bad. Young calves, veal calves. And you can see here, for example, that's just a Mycoplasma bovis. No typical case of necrotic pneumonia, just catarrhal lesion. That's a Mycoplasma bovis with Arcanobacterium pyogenes. Chronicle again, young animal. Right in the corner, RSV, and this is a Pasteurella multocida pneumonia, which was in there. So it's really lovely if you do a necropsy, but you should open it up, cut it in half, make your macroscopic diagnosis, but it's maybe not enough. You have to go further. And then we come to the live sampling of animals. There are different techniques. I use 2 personally. I use a swab, a deep nasopharyngeal swab, and a bronchoalveolar lavage. I do not use the TTL for personal reasons. If you have questions about that, you can ask them later. So on the market, you will basically find 2 swabs, a guarded swab and a non-guarded swab. Everybody will tell me, hey guys, you should use the guarded swab because the nose is contaminated with all kinds of germs. That might be true, but actually I don't use it. We have another way of approaching it. You can just use an unguarded swab, which costs like €1, less than €1 when you buy many of them. And anyway, it's way less than the other swab. If you use alcohol 90% is the key. You have to put alcohol on a cotton, and then try to disinfect the nose. So here I show you how long the swab needs to be. It needs to cover the distance from the nose to the medial eye corner. So this swab of about 16 centimeters, if you use this in feedlot cattle, it's worthless. It's just taking some pus out. It really needs to go to the lymphoid tissue, which is in the side, on the environment of the medial eye corner. So with the alcohol, you have to use a lot of alcohol. Don't be too, too cheap on it. And even go inside the nose on the cutaneous part, because that's where the contaminants are. And the results are actually quite remarkable. If you do disinfect with alcohol, you can see nice cultures. You can actually do something with your swabs. If you're not using it and it's not guarded swab, it's just polybacterial, and our bacteriologists will be very disappointed, and you as well. The technique is simple: fixate it, do not touch anything, go in the medial meatus, then advance and make a firm movement, because many bacteria live in close contact with the mucosa at that side, with the lymphoid mucosa. So you need to have some pus, sometimes even some blood. Don't do that, of course, but this is to show you where we took a sample. So that's the nasopharyngeal swabbing. Goes fast, you can do it by yourself when you put the calves in the corner, a whole group of them, quite quickly. So again, here to show you, here the pointer works, where you are sampling, you're just sampling at the lymphoid tissue at the end of the nose, where these bacteria also normally reside. And that's, of course, the problem. Everybody thinks it's not because you find it in the nose that they are responsible for what is happening in the lung. Of course, that's a criticism which is realistic. So that's why for years we have always been using these bronchoalveolar catheters, sampling of the lung. Either by TTL, you're not sampling the lung, you're sampling the trachea. You're making a flush of the netto efflux of the lung. Now with this ball catheter, you all know that you are in the cranial lungs, that is the pneumonia site. Well, with the ball catheter, you enter in the diaphragmatic lobe on the end of the lung. So that's also something which can be criticized. So we make our own catheters. The reference is there. If you need more information, I'm happy to give it. It's quite a rigid catheter because we do it in the field without any help. So then you have to really need a stiff catheter to do it. You need little things, some saline, which is sterile, a 30 cc syringe, so you just need 30 ml of fluid, and try to work a little bit hygienic with gloves. So the head needs to be up. That's the most easiest way to perform it. You go in after alcohol disinfection in the ventral side. And then when you're in the trachea, you can see that the calf starts coughing, that the tongue comes out, and you can actually feel your catheter moving around the tracheal rings. Then you have to keep on advancing just until the wedge position. It means a wedge position that your catheter is blocking a bronchus. That's at the end of the lung lobe. And then you can flush. So you need to be with at least 2 people, somebody holding the calf and then you doing the flush. And actually, this person here is most important because one person is injecting and the other, and then immediately aspirates. You have to keep your catheter in the wedge position, and at the end, you just retract 1 millimeter, and then the fluid pops nicely in. That's just a little trick to make it go quite easy. How can you see whether you have a good sample? Of course, in some cases you enter up in the room and you do not want that. Nice and clear, and you have foam. This foam is surfactant protein. You're just flushing it, and then you know that you have been in the lung. With a tracheal wash, you do not have this so nicely. We also look whether we have pus or other remnants inside of the catheter. Then we ship them in nice tubes, and we send them to the lab, or we bring them, in our case, at the faculty where we can do the rest. So please put them in the fridge. It's not worth if you are doing all the effort of taking the samples and then you just wait 48 hours and you just leave them in your hot car. That's not good, of course, you can imagine. So try to put them on a plate as quickly as possible. And our standard procedure is we do a culture medium for Pasteurella. We actually ask an antibiogram for each animal, because we want to know whether there are different strains present in a stable. Do a special culture for Mycoplasma species, that's also standard for us. And for virology, we tried many things, but actually the best thing, if you want the herd diagnosis, because that's what you want to know, what do I need to do for this herd, for every animal which is present in there. That's what you want. So the most accurate thing is actually use PCR. In acutely ill animals, take nose swabs and pool them. There has been a very nice paper in the recent edition of the Veterinary Record by Irish colleagues, O'Neill and others, and they have done this on a national basis. So they just send in swabs from animals with viral infections in there, so acute case of BRD, and then they could just see such a nice seasonal spread of viruses, like flu in human beings. So I hope that these guys will use this data to make a national surveillance system, that they can just warn farmers, warn vets, hey, BRSV is coming. So really, PCR for viruses, it's a go, because you know, it's present in my farm, yes or no, in sick animals. Pastoralacea are very difficult to diagnose correctly. I can talk hours about that, but I just want to give you one key message on how we approach it nowadays. We actually use the combination of swab and ball. I will show you why. So suppose you take several animals, 11 animals, the group, you take them, you take a ball and a swab in every animal, then you get these kind of graphs. For example, this is a profile of a herd which has Mycoplasma bovis problems. You see, with Mycoplasma, it's very contagious, as Edward also has described. You can just see that when it's present in the nose, it's present in the lung. So if you want to know whether Mycoplasma is there, use a swab. It will be more than enough, and you have specific cultures for that. So take them out like that. It becomes more difficult when you're talking about Pastoralacea. You can see here, for example, okay, 20% of my animals carry Pastorella multocida in the nose, but none of them was culture positive in the lung. So this is a typical carrier state situation in a normal farm. 20% of these animals have an amount of Pastorella which is higher than the detection limit of bacterial culture. And that's it. None of them is causing disease. None of them is being present in the lung right now. The situation completely changes when you have this kind of profile. You find in every sick animal you diagnose, you can culture Pastorella multocida, and in the lung you also find it. This is a typical example of a problem herd which has Pastorella multocida problems. In this herd you can only resolve if you take away risk factors, especially housing. If you do not do it, it remains endemic pneumonia. Now let's go back, and the same is true for Mannheimia. Mannheimia, you can just put Pastorella or Mannheimia in there. Here. These are the Histopheles somni results. Everybody sees that on the swabs it's quite low, no? Whereas it's overpresent in the lung. These are actually the results of the farm I showed you with the video and the smoke. The animals just had 39.5 fever, a little bit of cough, and they were poor doers. They did not grow enough. We performed the sampling, and then we see that many of them just have Histopheles somni being present in the deeper lung parts. And 20% of them is Mannheimia hemolytica carrier. So you know with this Mannheimia, it's present on the farm. It might complicate stuff in a period of time. But right now, what is causing the problems is Histopheles somni. Why is this difference here? Why is it not possible to diagnose it accurately with a swab? So these are cultures. We also tend to dilute cultures because we quantify it, but that's just for research reasons. Here you can see Pastorella multocida, which smells a little bit like a mouse, and then there you have Mannheimia hemolytica. But all the speakers will tell you that it's not always the hemolysis is not always present in every case, so be careful. This is a typical example of the results you get with a swab if you use alcohol. Nice, we have Pastorella multocida in the upper halfway, but we also have quite a lot of other bacteria, Streptococci, Proteus, E. coli, and so on, in the lower half. So it's contaminated, but bacteriologists will say, okay, I picked this one. Now look at the ball of the same animal. You have to look where the germs are, but there are actually two pure cultures of Pastorella multocida being present in the ball. That's also the reason why I'm quite confident that the passage of the nose actually does not contaminate as much as has always been stipulated in literature. So this is for Pastorella. This is how it looks like for Histopheles. I will manage it through. So for saving reasons, of course, if you take a swab and a ball, we use one plate. We put on one side the swab results and on the lower side the ball results. So then you have it on one plate, the same animal. It's easy to read it off. You can see here, this is the only one which was positive in the nose. The bacteria, they are there. Very small colonies, very difficult to see. And here you have contaminants. So in many cases, you just have overgrowth by contaminants, and your swab is actually false negative. In the lung, you do not have this competition, and here you have the different Histophilus colonies which are present in there. So that's actually the reason why, if you only use swabs, you will miss Histophilus somni. And other speakers will show you that there are ways to improve your Histophilus diagnostics, and that we might actually just be very much underestimating the prevalence of Histophilus somni right now in different countries. So what else can you do for diagnostics? I know that most vets really love serology. It's easy, you just take blood, you send it in the lab, you get the results, and when you're lucky it's positive, then you can show something to the farmer. Of course, that's not the way you are dealing with things, because there's hardly anything that you can say about one positive result. You have to use paired sera to prove any kind of causality, not even a causality, just a contact in a period that also the animal was diseased. So it's not that easy. For example, also for BRSV, you have to take into account that animals which have maternal immunity will not seroconvert anymore. So you might also miss them. Seroconversion, a 3-4-fold time rise. There are many semi-quantitative tests available. So of course, as we go into the field, we try to diagnose in several ways. We use them. I use them for research. I use them for diagnosing problem herds, with all the limitations and the difficulties of interpretation being present. BVD is a minimum. If you're from a BVD-free country, you're lucky. You might be screening. If you're not from a BVD-free country and you're having endemic pneumonia problems, serology for BVD is still the most cheapest way to have a quick look in the farm. These are veal calves. In the veal calves, some years ago, we did not really know what were the dominant pathogens being present in there. And still, it's not that easy to document it quite nicely. So we did paired serology. We took animals at arrival 6 weeks, 12 weeks, and 24 weeks, just before slaughter. And then you get these nice profiles. You can see here, for example, between 0 and 6 weeks, most of them actually seroconvert for Mycoplasma bovis and for BVDV and all the other viruses at a different level. Mannheimia, many of them seroconvert if you look over the complete cycle. Many of them seroconvert. But here it's between week 12 and week 24. You can see the little blue of the big blue bar at the end there. So there was seroconversion in these type of herds with the young animals, but it was at the end where we do not have any meaningful clinical problems anymore. So this helped us really to identify. Fortunately, I did not have a Histophilus somni ELISA at that time, because I'm really eager to see as well what is happening in there. So one possibility for us, we did not find it, Histophilus, in the veal calves, but we used swabs, and in that time, many animals received oral oxytetracycline. And you know that Histophilus somni is not quite the most resistant germ, so you might quite easily get rid of it without knowing it, actually. This is another approach. If you go to a problem farm, one visit, as we do as a service, then you want to have a look on what is happening on this farm. So you can do a cross-sectional seroepidemiology. You have 30 animals which you can sample, because on one of those commercial plays there are 30 spots. So if you do 2 samples or you do 30, it's the same price. So why not do 30? Why not have a look on what is happening? This is nothing new. In pigs, they do this for years, checking the serology results. They also check whether the animals are sufficiently vaccinated. In cattle, you have to be a little bit careful with interpretation. So I brought you today an example of a herd which does not vaccinate for anything. So you know what you see is actually just natural infection. So in the youngest animals, you can have a look at maternal immunity, because we know when calves have high levels of colostrum, just EGG, the likeliness of being classified as positive is much higher. So every herd which is good on the other tests is actually seropositive. You can see here that for Mycoplasma bovis, it's not present on this farm. You can see that for all the others, maternal immunity looks quite good. What you expect then is it should decline. Maternal immunity disappears about 3 months' time. So we should expect a line like this, from here, nicely to the 4 to 8 month section. Every maternal immunity declines. But you can see here that the red bar stays. And the red bar is BVD. So this was a herd in which, in kind of a stupid way, we were convinced by the veterinarian again and again that BVD was okay, and in this way it just burned up again. That this was actually the problem in this particular herd. If you want to motivate people to vaccinate, you have to show them whether they are at risks, yes or no. You are not going to insure something here in France against snowstorms when you know that there are no snowstorms here. So for a farmer, that's the same thing. If you know that a pathogen is present in the neighborhood, in your country, or on your farm, then you might be more eager to start vaccinating. And that's exactly what you can do with these kind of serological profiles. You just show in animals which are a little bit older, 12 to 24, that they already have antibodies against BRSV, PI3, whatever you want to show. So they have been in contact, there has been passage of these pathogens on the farm. So this bit, it's not science, absolutely it's not science. You can talk a lot about it, but anyway, it helps us gaining insight in the epidemiology of a given farm. So my personal take-home message for you is that you have to realize that our rules of play have changed. Whereas we used to have our drugs, let's be honest, we make our money with our drugs, of course, as our vets. Well, this thing tries to change. So we have to reinvent ourselves with a different business model. And in this business model, prevention will always be more economically efficient than the cure. In vivo diagnosis, necropsy is important. You should do it if you have the opportunity, but we are late. We are late, and if you have diagnostic results on necropsy from one round, how do they correlate with the next round? So really this in vivo diagnostics, they will become more important. But please do not take what I told you here today as fully granted as the gold standard, because there's so many questions. If you look into this, I do this on closed herds. There I only have 1 or 2 different Bacterial strains. What about veal herds? What about feedlot herds? What about all this complicated situation where Edouard showed the dynamics of these monohamia? It's far, far more complicated, and more research really needs to be done on that. This in vivo diagnosis can also help you to prioritize. I told you, when you have an whole list of risk factors, you as a vet, you know all of them, but do not communicate all of them to your farmer. It will not work. You have to have the feeling to know what are the 3 most important. And that's ones you need to pick out. And in function of your pathogen, for example, histopholosis, stocking density is a very important one. And then my last sentence, you can read it by yourself, but we have to realize that no governmental or any societal support will remain for us to use antimicrobials where we can actually prevent it by a better husbandry or better management. And vaccination is for sure one of the key elements, one of the key tools which is in our hands to achieve this new mission for us. So I would really like to thank you for your attention, and questions will be seen later on. Thank you very much.